an informative talk on fungal keratitis by Dr. Venkatesh Prajna.
So good morning. I'll be talking about the diagnosis and management of fungal keratitis. So I'll first talk about a little bit about the diagnostic part of fungal keratitis and then go to the management part. In the diagnosis, how do you actually diagnose fungal keratitis? You can do it by clinical findings, look at investigations which you can do in your clinic. Microbiological investigations, as Prashant mentioned, is very crucial, and also the newer version of AI, which is now going to be in this realm, which will be extremely useful in the future to come. So in the clinical findings, these are the typical features which are described in the textbooks. Out of all these things, the only thing which is very typical for fungal keratitis is the feathery edges. Even though the other parts you can diagnose in the early stage of corneal ulcers, but in established cases, by really good research studies, it has been shown that the only thing which has of very, very clinical significance is the presence of feathery edges, especially like this. When you have feathery edges like this, you're fairly, it's confirmatory for fungal keratitis. But you see this case, this is how patients usually present, very, very non-specific. And you can see it in the periphery here is something like a lesion, like a central lesion. But then the first thing is to identify it or delineate it using fluorescein staining. And especially when you use fluorescein staining, you start seeing this feathery edges, which was not clear before you use fluorescein staining. So our advice will be not to shy away from fluorescein staining, at least in the early part of your career. But the same fluorescein staining, if you put it in a cobalt blue filter, whatever you see now becomes much, much more clearer. The feathery edges, almost like a flower pot appearance, like the flower pot, some sparks coming out of it. So this is very, very typical. And if you have not used this, this is how it would have looked like it, and it would have been very, very non-specific. So these are very small things which you have in your hand, which you should use, and you will get remarkable results. In the clinical investigations, the only problem with confocal is they have stopped production of confocal. There are only 60 confocals around in the world. And the only big problem for that is there's no big market for this. And so this may be history. But confocal microscopy is very useful for acanthamoeba keratitis and fungal keratitis. It cannot be used to identify bacterial keratitis because the size is very small. In confocal microscopy, initially there were studies which said that you can differentiate fusarium and aspergillus. But a study from our institution, we were very clear that the IVCM cannot be used and the branching angles at 90 degree and 45 degree are also not very specific for fusarium and aspergillus. So that was the clinical investigation. How about the microbiological investigation, smear, culture, and recent advances? One of the things which you should really do is to take the specimen correctly. Unless you are going to take the specimen correctly, the microbiologist is not going to give you a correct answer. And in one advantage in fungal ulcer is you can take it like a plaque. And when you take it like a plaque, it serves two folds. One, it gives diagnostic material for the microbiologist. Second, it acts as a therapeutic debridement so that the drugs can actually reach the deeper parts of the cornea in a much, much more a perfect fashion. So in the light microscopy, if you have samples only for one smear, then do gram stain. Because in gram stain, you can see fungus, you can see bacteria, you can see gram positive, gram negative bacteria, you can see acanthamoeba, you can see everything. So if you have sample only for one specimen, one test, do gram stain. Otherwise, a KOH is a simpler test for detecting fungus. Any clinician who with repeated examinations can develop these expertise. So all things which look like a filament in KOH is not fungus. As you can see in this, you can have fungus, which is much more broader, something like a sugar cane, while nocardia is much more thinner, like a string, like a vermicelli. So that is the difference between nocardia and fungus in a KOH. So that is one thing you need to understand, that you can have these kind of things in both these organisms. Culture is important, especially we propose that Fusarium keratitis and Aspergillus keratitis have to be treated differently. And in our country, we need to be careful in two fronts. In our country, in the US, it's very easy to treat a corneal ulcer because 90% is caused by bacteria. So you will not be wrong if you are going to treat it with antibiotics. But in India, 50% is bacteria, 50% is fungus. But adding to the complexity is the north-south divide. In north, it is only Aspergillus, and in south, it is mostly Fusarium. And the treatment part for Fusarial keratitis and Aspergillus keratitis may be slightly different. So PCRs are recommended, not really required for each and every case, only if you don't have answers to your culture and smears. This AI part, which once again this paper was referred by Prashant in his talk, if established clinicians, established cornea people can only differentiate it 65% of the time by clinical samples, because in textbooks you see very distinct features. This is bacterial, this is fungus, but in real life patients don't present like that. And so it becomes very difficult, and unless you have ancillary support system like microbiology, you are not going to differentiate bacteria and fungi. And so there is a need for something better than that, better than the clinical part, and that is where AI comes into play. And we have now published that if you compare it with clinicians, and if you compare AI like mobile net and other convoluted neural networks, it is very clear that in the future, AI is going to take over this. Maybe it may be just adapted with your slit lamp. Maybe it will be adapted with a very simple instrument, so that it is not a complicated stuff we are talking about. Maybe it may be just with your mobile phone itself, which may give a differentiation of bacteria and fungi much more better than a clinician. So we finished the diagnosis. How about the management? The management, the treatment is medical and surgical. Medical, you can use the antifungal drops either topically, intrastromally, or orally. In topically, there are mainly natamycin, which was discovered in the 1960s, still remains as the drug of choice. Now, why does natamycin still remain potent? Because usually you hear that a drug which is discovered in 2005 works very well for 2 or 3 years and then develop resistance and goes away. But natamycin, only one important thing to understand is it is used only in the eye. It is not being used systemically. It cannot be formulated to be used systemically. So it's used only in the eye. And most importantly, it is not used in agriculture. We are talking always about antimicrobial resistance and other things. What the biggest culprit for development of antimicrobial resistance is its use in agriculture. So natamycin is still potent because it is being used only in the eye and not being used in the agriculture also. It's still, in the study which we did, we found out that natamycin was better than voriconazole, And especially so, the difference becomes much more stark between Fusarium and Aspergillus. Fusarium, there is no doubt that natamycin is a much, much better drug than amphotericin. Intrastromal, the dose of voriconazole is 50 microgram in 0.1 ml, and amphotericin also has been suggested even though it's toxic. But randomized control trials have shown no added benefits of using adjuvant intrastromal antifungals. Though it has been postulated that instead of intrastromal, if you use intracameral, amphotericin B has some benefits. How about oral antifungals? The indications are when the lesions cross the limbus, if there is scleritis, if there is endophthalmitis, then there has got some role for these drugs like ketoconazole, voriconazole, fluconazole. But these are toxic drugs, and the liver function tests have to be done and have to be monitored if you are going to use it for a long period of time. But for keratitis, there is no benefit in adding oral voriconazole to the topical antifungal agents for severe fungal keratitis. Dr. Namrata Sharma has popularized this concept of TST protocol, the topical systemic targeted therapy. The first line, there is no doubt, you start with topical natamycin 5%, and in case it doesn't respond, you add systemic therapy in severe ulcers, and in the third line of treatment, intrastromal and intracameral, and fourth line is TPK. But with all this, if the ulcers are not healing, always check for diabetes mellitus. The patient may be a 17-year-old patient. The patient may be an 18-year-old patient, but please do check for diabetes mellitus before you have to treat this patient. Establish whether there is any chronic dacryocystitis. Ask the patient to show you the medicine and ask them to tell in their own words on how they are using these medicines. I have seen patients using hometropin drops every hourly and natamycin for 2 times a day. Sometimes patients wouldn't have understood what we have told in our rush for seeing more patients. And the contamination of medications also is very, very important. The drug which we have given it to them, if they are not keeping it right, that may be contaminated by bacteria. And so instead of fungal ulcer, you will be converting it into a fungal plus bacterial ulcer. So this is very important. How about the surgical part? Cross-linking, therapeutic keratoplasty, and miscellaneous surgery. In cross-linking, if you just use Dresden protocol, there is no benefit. However, there seems to be some benefit in bacterial keratitis. But if you change the photosensitizer to rose bengal instead of riboflavin, there seems to be some benefit, especially in fusarial keratitis. There's a distinct difference between fusarium and aspergillus with regard to rose bengal assisted photodynamic therapy. How about therapeutic keratoplasty? Unfortunately, in our condition, in India, therapeutic keratoplasty is the single largest indication for keratoplasty, and it is not a great surgery. It's almost like an amputation surgery, but the indications are perforations, progressive non-healing ulcers, especially if they are non-healing, but if they are not progressive, I would still request you to consider continuing your topical therapy. Take the therapeutic keratoplasty as a last indicator. Also threatening to involve the limbus, definitely there is an indication. So the aim of therapeutic keratoplasty initially is not to provide vision. If the vision is coming, then it's fine, because I find especially the fellows, they want to do a round graft with beautiful sutures, but the main indication is to get rid of the infection. So even if you do a sort of an irregular graft, as long as you take the infective part away, then you should be happy this thing. So these are the surgical steps, a routine thing, but these can be the sequelae. Sometimes you start off with a pre-op here and you end up very well. This is very rare. Usually you can have a active fungal keratitis with increasing infection, go for a TPK. Earlier, initially it looks clear, but over a period of time, there may be a rejection and there may be an ultimate failure. Or worse, it can be a fungal keratitis for which we did a graft, after 30 days, the infection can recur in the graft. So there can be 3 sequelae with regard to therapeutic keratoplasty when you do for a fungal ulcers. So in conclusion, it is a big public health problem. There is an estimation that in India, around close to 9 to 10 lakh people get infective keratitis every year. 9 to 10 lakh, and out of that 50% fungus, and prognosis is definitely poorer than bacterial keratitis. The choices are limited, and there are need to explore different cross-linking strategies. I told you the rose Bengal works better, but then there are definitely some more time to go before we develop a good cross-linking strategies. But TPKs can be considered as a last resort, but it has a higher chance of reinfection. Thank you very much.